So Dr. Nikita Goel, yeah. So she'll be presenting a case, Beneath the Retina, a Battle Against Bleed. So all yours, Dr. Gagan.
Thank you. Good afternoon, everyone.
This video represents a complex case of massive subretinal hemorrhage in a 67-year-old female. The patient presented with hand movement vision in the left eye with altered vitreous hemorrhage, and ultrasound confirmed vitreous hemorrhage with prominent mounds of subretinal heme. A surgical approach was planned, so we began with a standard 25 gauge pars plana vitrectomy, clearing the vitreous hemorrhage. A core vitrectomy was done, and massive subretinal mounds were noted. So a subretinal injection of tissue plasminogen activator was delivered using a fine 41 gauge cannula. Then a fluid air exchange was performed and silicone oil was instilled. Despite initial efforts, post-operative evaluation revealed worsening of the subretinal hemorrhage with increased clot burden and a retinal detachment under silicone oil. Hence, a second intervention was undertaken, and after silicone oil removal, a limited temporal retinectomy was performed. A dense subretinal clot was carefully evacuated using aspiration and intraocular forceps. The subretinal heme was aspirated. The dense subretinal clot was carefully fragmented and aspirated using the vitrectomy cutter. Intraoperatively, a full thickness macular hole was noted, and under perfluorocarbon liquid, the internal limiting membrane was peeled following brilliant blue dye staining. Fluid air exchange was done, and the margins of the retinectomy were carefully lasered. Silicone oil was then injected. Post-surgery, we can see that the subretinal heme had cleared, retina settled, and the FTMH had closed. Thank you.
Thank you. I think very well managed. I think the only thing was that I don't know if TPA would have really worked in this case, because initially there was no role of TPA.
Yeah. But then what else could have been done at that time? Because like I asked a lot of people, so some said we could just leave it like that. So this was a one-eyed patient also, and that's why in the first case I used silicone oil instead of gas. That was like...
No, that is okay. I think there are two things. One thing what I would have done different is that one is, yes, I mean, leaving it behind is a different decision when you discuss it with the patient, that if you get this kind of a bleed, definitely you've already lost the RP, so there's not going to be any central vision anyways. Yes. That is one. So secondly, if we want to aggressively go inside and do, number one thing is that TPA is only going to work if the hemorrhage is fresh. Yes. This looked more like a like old a clotted old hemorrhage, and probably that macular hole also formed because of pulling it out. Yes. So the only different thing, if I wanted to go in and tackle this, would have been a much more larger retinectomy. So your retinectomy was very small. Yeah. So this kind of so this exactly. So so that little retinectomy that you made, the smile incision that you made, basically there was not enough space, and that is why you couldn't reflect. So if you would have reflected the retina completely, you would have been able to see till where your clot is adhered to, and then you would have been able to take it out much more easily. But I think very well managed. The only other thing would have been that if you would have made a larger retinectomy, you would have had to do a direct PFCL oil exchange and not an air fluid oil exchange. So I think probably, yeah, 2 surgeries, but could have been just one
Yes, sir.
if it was taken that way. But nevertheless, yes, TPA does work, and but I personally feel that subretinal TPA in a hemorrhage, in a breakthrough hemorrhage which has already gone white like this, will never work. So I think that was one indicative sign that you could have just converted to a large retinectomy if you wanted to take all the hemorrhage out.
Yes.
I think as far as what you've been advised, I think we need to be a little judicious also, because in this case, yes, I would have definitely also gone ahead and taken out the hemorrhage because it was already crossing the arcade, the equator.
Yes.
But in case this was not crossing the equator and it was a clotted hemorrhage, just kind of not very localized, then I would have not done a retinectomy, because I would have tried to save the peripheral retina and given him more peripheral vision than anything else. So ultimately, it's more about ambulatory vision. So that tough decision always stays, right?
Yes.
Thank you, but very well managed.
Thank you, sir.
Thank you very much.